Good morning, everyone. We're going to go ahead and get started. Our next speaker, we're doing virtual. She was unable to be with us today. We really miss her. She's been at our conference numerous times. She does give a great talk. So I wish she could have been here, but I know she's got other things she has to deal with. But our next speaker is Dr. Goli Moab. She is an associate professor of pediatrics at the University of Pennsylvania School of Medicine. She has co-appointments in the divisions of endocrinology and oncology at Children's Hospital of Philadelphia. She received her bachelor's degree in French and biology from the University of Missouri-Columbia and her MD summa cum laude from the Pennsylvania State University. She has subsequently completed a residency in pediatrics, followed by a dual and combined fellowship in pediatric endocrinology and hematology and oncology at CHOP, along with a Master of Science in Clinical Epidemiology at the University of Pennsylvania. Goli's clinical research program focuses on addressing endocrine late effects and metabolic outcomes in childhood cancer survivors. Goli is a member of the solid tumor group at CHOP and treats patients with endocrine tumors as well as endocrine late effects after cancer therapy. She is the founding director for the program in pediatric survivorship and outcomes research, director of the endocrine late effects after cancer therapy program, and the associate director of the thyroid center at CHOP. She is an active member of the Children's Oncology Group, the Childhood Cancer Survivors Study of Chronic Disease, the Chronic Disease Working Group, ASCO, ASPHO, American Thyroid Association, and Endocrine Society. And she'll be talking about the endocrine late effects of childhood cancer therapy. Dr. Moab.
A very warm hello and greetings to everyone from the City of Brotherly Love. My apologies for not being able to be there in person. Chicago is definitely a favorite city that I usually use any opportunity to visit Chicago, but under the circumstances, I appreciate the understanding to be able to join you guys virtually. So addressing endocrine late effects for patients who've had neuroblastoma therapy, but more specifically high-risk neuroblastoma therapy is really a cornerstone of what I do with this unique expertise and double, training that I have in both oncology and endocrinology. And this has really kind of afforded me the opportunity to work with the high-risk neuroblastoma population. And I certainly really appreciate and enjoy that. So hopefully what I will share in the context of the time frame that I'm given, some of the highlights of the endocrine late effects, and certainly happy to address any questions in more detail. But before I get started, I wanted to reassure everyone that I had no conflicts to disclose. And I always like to start this presentation, and as Pat kind of pointed out, I have been part of this conference for several years now, and I always like to start with this slide that even though it was published in 2009 by Dr. Lisa Diller, I think it's such an important foundation slide. So I think it's one of those studies that really brought something to attention. And what I kind of want to, get your attention or hone your focus on is that area in the yellow box. And so this basically slide is a table from the 2009 JCO or Journal of Clinical Oncology paper that just highlighted the chronic health conditions in survivors of childhood cancer. And from an endocrine perspective, when you compare survivors to siblings, and when you look at chronic health conditions, and we like to actually grade those 1 through 4, and it just has to do with severity. And just to give you an idea, if you actually have a chronic health condition that requires medication treatment, that's considered a grade 2. And then as the severity and the life-threatening aspect that can result in morbidity as well as mortality, that's really what a chronic health condition grade 4 is. So if you look at that overall, the risk of having an endocrine late effect in childhood cancer survivors is about 6-fold higher. But when you bring that lens in closer to more serious health-related chronic health conditions, that relative risk essentially does not change. So it just means that not only our patients are at risk for chronic health conditions when it comes to endocrinopathies, these are actually serious endocrinopathies that over time certainly can have, morbidity as well as mortality. So I think it's important at least to have that appreciation. The other thing that I want every family to understand is that in general, curing cancer, while it's always our goal, in reality, it actually comes at a cost. And when you actually look at patients in general, this is an important statistic to at least take into consideration as a parent, because when you actually have to see a late effects provider, it should not come as a big setback, because I think that this is an important understanding in terms of the challenges of getting through high-risk neuroblastoma therapy. 9 out of 10 survivor of childhood cancer, so this can actually even be standard risk ALL, will be diagnosed with at least one chronic health condition. So I think that that's a really important understanding. And we know that endocrine disorders are the most common morbidity in childhood cancer survivors, and particularly survivors of high-risk neuroblastoma really have a large prevalence of endocrine late effects. And I think that this has been, published, and we'll spend some time kind of highlighting that. This is a study that I did with my mentor back in the days, Dr. Chuck Sklar, who was at Memorial Sloan Kettering and also took care of a fair number of high-risk neuroblastoma survivors. And what we actually did in this paper is we basically looked at survivors as they had kind of reached into adulthood across different, lifespan, and just we took, common endocrine problems that you see in the general population. So thyroid-related problems, obesity, and diabetes. So these are not anything that really requires a particular, let's say insult like surgery or radiation, but these are common endocrine problems that as we get older, it tends to be prevalent in the general population. So I think across the board, when you compare the survivors that are high risk, so those who, for example, who've had neck radiation, which puts them at risk for thyroid-related challenges, abdominal radiation for diabetes, so those are the survivors in the yellow boxes. These survivors have a much higher risk for developing these chronic health conditions. But I think what's really important to look at is that even survivors who have non-high risk, so traditional chemotherapy, when you look across general endocrine, conditions, the survivors have a much higher risk of developing these late effects compared to their siblings. So in general, there's really no such a thing as a low-risk survivor, but I think what's important to realize that certain types of therapeutic exposures and the intensity of high-risk neuroblastoma really falls into that, group of intensity of exposures that really predisposes our, survivors to endocrine late effects. So what I want to spend some time is I'm going to focus on growth, because by far that's the most common late effect that is one of the hallmarks of high-risk neuroblastoma survivorship. I do want to talk about thyroid late effects and just sort of give you some background information. We're going to spend some time talking about puberty and gonadal function, because I think that that's equally an important area. And then I want to highlight some of the importance of what I refer to as body composition, especially muscle mass, because I think that that's an underappreciated area of late effect in our survivors. And then lastly, I will kind of bring the importance of some of that body composition late effects into the downstream risks with diabetes mellitus. So hopefully I'll be able to cover these. They're only going to be highlights and as best as I can in the time frame that I have, but I want to make sure that I use this opportunity to help educate parents and families with children of high-risk neuroblastoma survivors, so they can really advocate on their behalf, and more importantly, I think as a parent, to validate if there are certain concerns that you have that potentially you may need to reach out to those of us who see most of these patients and can provide you with the guidance if that guidance is not available to you locally. So growth is one of the most common challenges that I see in, survivors. I see in cancer survivors in general, but I think it's one of the hallmarks of survivorship with high-risk neuroblastoma therapy. The growth chart that I show here on the right is just really to show this is a child that mid-parental height, or the genetic potential, was at the 90th percentile. That's the bubble on the right upper hand corner there. So that's the mid-parental height. So this is a child that was really destined to be tall. But as you can see, not only that child is not tall, it's markedly below the genetic potential. And as they went through puberty, just in general, like a very limited growth spurt, and just overall significant short stature. So that's actually more common in survivors of high-risk neuroblastoma therapy than actually, compared to some of the other survivors. And I don't think it's just a one specific cause that results in that. I think it's multifactorial. And, certainly some of the unique ways that we treat neuroblastoma has more of like a compounding effect or a role. But I think one of the things to just remember is that nutrition plays a huge role. So this is one reason, for example, when I'm on service as a solid tumor physician, working with families actively going through high-risk neuroblastoma therapy, I really highlight why it's important to kind of make sure that there is more of an emphasis on, improving nutrition, even if that means NG feeds and enteral feeds, because I think that down the road can have negative consequences on growth, for example. But when we have to do radiation as part of local control for high-risk neuroblastoma, the spine gets radiated, and you really cannot undo the effects of radiation on the spine, particularly as most of our children are toddlers when they go through their radiation therapy. And so the growth plates in the spine really can be impacted, and that's one of the reasons where the growth can be suboptimal. We're going to talk about the role of cis-retinoic acid. I know that this is controversial, but at least I want to share some of the studies that I have led here at CHOP with colleagues at other institutions, just to sort of give you an appreciation of, while it's an important biologic in high-risk neuroblastoma therapy, it has its known effects, certainly with respect to injury to the growth plate. And then, the other hormonal effects that result from high-risk neuroblastoma treatment therapy certainly can have additional effects. So if the child is not going through puberty, if they have thyroid-related issues that are not adequately or properly recognized and treated, those all can have an impact, on growth. And so I, kind of some of the hallmarks to just realize is that we know that there's a significant decrease, not just during therapy. In the next slide, hopefully I'll be able to, with the next few slides, show that to you. And we know that, for example, even survivors who have growth hormone deficiency, let's say they had ocular disease and they needed to get emergent ocular radiation. That happens sometimes when we have metastatic neuroblastoma to the orbit, or if patients have, skull disease or reasons where there is cranial radiation to sites of metastases, that puts the pituitary at risk for radiation exposure. So we know that those survivors, for example, are at much higher risk, and the response even to growth hormone is not as adequate as, let's say, other survivors who did not get neuroblastoma therapy but equally developed radiation-induced growth hormone deficiency. So I think that certainly is one of the hallmarks of this survivorship, in the sense of that it's something more unique to the neuroblastoma therapy. Before I show you some studies on growth, I want to make sure I have you understand, when it comes to growth, we talk a lot about Z-scores, and so understanding what that concept means, and that is the role for this slide. So that's just basically a standard deviation, but a Z-score of 0, as you can see here in the middle, actually corresponds to the 50th percentile. So when we say someone from a growth perspective, like this is the baseline is at a Z-score of 0, so that's kind of on average where there would be the 50th percentile. So as you can see on this study that was done by, the group at Boston, led by Laurie Cohen and Dr. Lisa Diller, as you can see here, in general, by the time our survivors, who actually are, toddlers, overwhelming majority of these patients are fairly young. So there's a significant drop that actually happens as a result of diagnosis and treatment of high-risk neuroblastoma. So as you can see, all of these patients, and again, this pink line is the 50th percentile. So majority of these patients actually are below the 50th percentile. They have further decline in their growth. And then even when they are appropriately seen and evaluated by endocrinologists and started on growth hormone therapy, the response, really, these patients have marked short stature, and their Z-scores are essentially either within -2 or -3. So on average, these patients are at the, less than the 10th percentile. So this really kind of signifies the challenge of, short stature that's prevalent in high-risk neuroblastoma survivors. So we are actually in the process of writing the data from this beautiful study that was an example of collaboration between multiple institutions and led by the Children's Oncology Group. Dr. Lisa Diller, as well as Dr. Tara Henderson, were the PIs for this study, and a fair number of us were co-investigators. So I was the endocrinologist as part of this study. And so some of the hallmarks that we based on the data evaluation of over 300 patients who are survivors of high-risk neuroblastoma. Again, what we're seeing is that short stature is a significant hallmark of our patients, whether they are the young patients who are shortly after completion of therapy or years from their therapy. And we hope to actually provide some more detailed delineation. And hopefully by next year at this time, if I'm in this conference, I can, share the published data. But we have some exciting data that hopefully should be coming out soon. So what I want to talk about is just, I brought up the word cisretinoic acid, or just the impact. And I think that this is an important drug in high-risk neuroblastoma therapy. There are some questions of whether now, with the advent of immunotherapy and some of the changes in neuroblastoma therapy, are we gaining much impact by the use of cisretinoic acid? And I don't think that there is, at least a genuine agreement within the oncology community. But I want to introduce cisretinoic acid from a lens of an endocrinologist. So we know that cis-RA is just basically a vitamin A derivative. It's a hallmark of neuroblastoma therapy, but it certainly has been introduced in other, cancer treatments, for example, in juvenile myelomonocytic leukemia, not to the extent of neuroblastoma, but we certainly use cisretinoic acid. And back in the day, the earlier introduction of cisretinoic acid in more of a younger population was through the dermatologists when they used this. This is as part of Retin-A for acne and skin, and that there at least were some earlier reports of abnormal growth or early cessation of growth plates or premature closure of growth plates. And some of the first kind of concerns about cisretinoic acid and the impact on growth came when for calves, and actually in the farming industry, vitamin A was used to enrich some of the hay that was given to cows, and the calves that actually were exposed to significantly higher levels of the vitamin A derivative had something called hyena syndrome, where their lower extremities had growth plates had fused, and so they had really short legs. And that kind of was one of the hallmarks of a beautiful series of experiments that really led to showing the impact of cisretinoic acid on the growth plates. This is an early study that I actually looked at cisretinoic acid actually in a brain tumor survivor. So this child had medulloblastoma, which is a brain tumor, and was treated as part of a protocol for metastatic medulloblastoma that also included cisretinoic acid. And these patients actually get, because of their brain tumor diagnosis, much higher doses of cranial radiation as well as spine radiation. And this patient, not surprisingly, was diagnosed with growth hormone deficiency. We started her on growth hormone, and then she initially was responding to the growth hormone, and she started plateauing. And so we were looking at what the standard way the endocrinologists at least use to evaluate the openness of the growth plate, which is this really archaic way of evaluating that using a bone age. So the growth plates actually look wide open on the growth plates, but given that she'd really plateaued, which did not make sense, even her growth factors and everything really highlighted the adherence. When we imaged her lower extremities, what we could see actually was complete fusion of her lower extremities. And when we measured her arm span, she actually was responding to the growth hormone by changing the arm span, but it was really the lower extremity fusion that, resulted. So I think that was one of the at least making the medical community, at least on the pediatric side, aware that even, when you have such a young skeleton, like someone who has high-risk neuroblastoma, and we have to introduce as it's necessary to, overcome some of the challenges of this disease, it certainly can have unique late effects, especially with respect to the musculoskeleton. So as part of the lamentation that we really don't have good ways of kind of looking at the growth plate and assessing overall how the growth plate is, particularly in the long bones. A colleague of mine, Dr. Diego Jaramillo, who is a well-known pediatric radiologist with expertise in musculoskeletal. So he and I basically kind of pooled our thoughts and efforts together with the goal of kind of developing an imaging modality that just kind of provided a better lens into the growth plate. So as part of that, I think this picture kind of shows you if I wanted to kind of get a better assessment or do a biopsy of what a growth plate looks like, this is what we would start off with. So it's just these beautiful pink tracts. These are cartilage. They line up. They are very much influenced by growth hormone. And then subsequently, as someone goes through puberty, by the puberty hormones. But this is where sort of the active part of the growth plate is. So the P is for physis. And if you did conventional MRI and we can just superimpose that, all you still get is just basically a line. So it's just some, kind of view into the growth plate, but it does not give us that beautiful kind of geometric architecture. And so this is where something called diffuse tensor imaging, or DTI, where it actually uses the water diffusion in these cartilage tracts, builds these beautiful parallel tracts that are shown in this, blue columns. And that really is a nice way to demonstrate what a healthy active growth plate that's responding to growth hormone looks like. And then for children, I think it's also important to realize that we don't always have growth plates that are available and responsive, but particularly it's the hallmark of what happens through puberty, which is not a surprise, as parents know, as well as everyone, that there is a growth spurt that usually comes with puberty, and there's a fair bit of coordinated actions that happen. And so as you can see in a prepubertal child, there certainly are presence of tracts. But as a child is going through puberty here, you have marked increase in the tracts. They're fairly organized. And then as puberty, completes, these tracts get completely disorganized. Sorry, these tracts get completely disorganized, which is really the hallmark of cessation of growth after, completion of puberty or the closure of growth plates. And so what we did was to basically propose this as a study in specifically looking at high-risk neuroblastoma survivors. And so compared to age, sex, and race-matched healthy individuals, because what we really wanted to make sure is we looked at what healthy growth plates look like, and then also within the high-risk neuroblastoma population, specifically those who needed to be on growth hormone, and what does the growth plate of someone who is responding nicely to growth hormone and those that are not. And as you can see here, so in 2 males here that I was treating with growth hormone, and one based on just linear growth, just not responding to growth hormone, versus someone who is at least very appropriately based on linear growth responding, you can see the difference in the tract. And then when we looked at the cohort total as a whole compared to healthy controls, as you can see, the tract concentration is significantly lower in our high-risk neuroblastoma survivors, and the height z-score for those individuals directly and linearly correlates with the concentration of the tracts. And so this has now led into an NIH study that we're leading at both CHOP and Columbia University. And as part of this, we're actually better characterizing as children go through puberty with respect to what happens to their growth plate. And then a specific aim, we're looking at patients who have a diagnosis of growth hormone deficiency and require treatment. So we look to see what the tract responses are. And our hope is with this study, we can actually validate what is a nice way to get better, opportunities to provide predictions of growth potential. And this would be obviously very important for patients who are not responding, let's say, to growth hormone therapy. So we are not exposing them to inadequate or to unnecessarily duration of growth hormone treatment. And then also, when is the right time for certain types of surgery, like leg lengthening surgery, where the orthopedic surgeons really need our help as endocrinologists to provide them with opportunities and growth potential. So I think that this hopefully will have applications that we can bring this to the clinics. And we're right now in the 4th year of the grant, and we have done really well with recruitment. So I think our data should be, hopefully able to make a case and, and improve, I think, the health and the outcome of a lot of pediatric patients. And then one word to make sure, I know there's a fair bit of fear in growth hormone therapy. So there are some survivors who actually have diagnosis of growth hormone deficiency. And I think it's really important to realize, and I think that this study by Dr. Sklar, that was, I think one of the hallmarks of understanding that if a child has had a cancer diagnosis and have achieved remission and they develop growth hormone deficiency, whether they get treated with growth hormone compared to survivors who did not have growth hormone deficiency, the overall, risk of recurrence is exactly the same. So it's superimposable. So you're not really going to change risk for recurrence by treating a survivor who has growth hormone deficiency. And the reason I highlighted is that there were a fair number of neuroblastoma patients in that cohort. So it wasn't just leukemia patients or brain tumor patients. So I think it's just sufficient to say that if a child develops growth hormone deficiency as a consequence of their cancer treatment, it's important for us to address that and treat that, and it does not really change the risk of recurrence. So I can spend an entire lecture on growth. I spend a fair bit of time actually during my visits with families on growth, but I think in the interest of time, I'm going to shift to thyroid because I think thyroid is equally an area that requires attention in our patients and survivors. And thyroid screening is not only a common, laboratory assessment, but I'm here to at least make a case that there are some instances for our patients that would require additional surveillance, like using thyroid ultrasound. So again, this study that we did, based just looking at time in general from radiation exposure, I think it's not a surprise, or at least the graphs are fairly telling, that our survivors have both an increased cumulative incidence of thyroid nodules as well as thyroid cancer. And this is a much bigger deal, especially if a patient is younger at the time of their radiation exposure. And it's not the high dose of radiation, but it's usually the low dose radiation. And so the CCSS cohort is not a cohort that is going to have a number of MIBG patients, but I want to make sure I put that in there, that patients who are treated with MIBG treatment, that is similar to radioactive iodine, just as the Chernobyl experience taught us, et cetera. And so that's one of the reasons where for us at CHOP, where we have a thyroid center, it's a very multidisciplinary group of, different providers, and we really bring, expertise, and it's very patient-centered. It is one of our goals is to just really bring a more definitive surveillance for patients who we identify are at risk for potential thyroid nodules and thyroid malignancy. And we actually do screening thyroid ultrasound as part of our clinic. Now, I do admit that this is something that is fairly unique to providers, those of us who are comfortable with looking at our own thyroid ultrasounds. I don't have to rely on a radiologist to tell me whether this nodule, if I identify as needs a biopsy or not. And by definition, we don't necessarily biopsy every nodule that we identify. And I spend a fair bit of time with the families to educate the families, parents, to just say, your child is getting a thyroid ultrasound. Do you understand? Do you know why? We go through the reason why, especially, your child had MIBG treatment at a fairly young age. What we need to do is to, basically use a fairly, useful modality that in and of itself with thyroid ultrasound, you don't bring in radiation into that equation. And what we want to do is to just identify nodules. And some nodules we just basically have to acknowledge and we follow them over time. And there are some nodules that we may need more information with respect to getting a biopsy. And so that is sort of like a schedule that we use depending on how old the child was at the time of their treatment. And I think for our high-risk neuroblastoma survivors who now, especially where MIBG is part of upfront induction as part of some of the protocols, it is important at least to have like a baseline ultrasound evaluation somewhere between 3 to 5 years, from their, treatment. And I will be honest to say that this is a big area of controversy and not readily accepted by many at COG and the national levels. But we recently also published our results. And I think in the hands of, as I said, the right provider, this is an important screening tool that you certainly can avoid unnecessary anxiety, because you're you're telling the patients, you're educating the patients what you're looking for. And at the same time, if a nodule is abnormal, you're actually intervening before it is identified at a time that it is malignant with lymph node metastases. So I think that that's, just an important, I think laboratory evaluation for thyroid is important, but equally, I think some of the, more advanced ways of proactive screens to just make sure based on treatment exposures, we, are helping our survivors in terms of kind of intervening before things, are more, advanced. And again, the outcome of thyroid cancer, no matter what, is very good, even if there is, let's say, lymph node metastases in our survivors. But I think, the treatment, whether you have to give someone radioactive iodine or not, I think that those to me are it's the devil in the details that really speaks for, surveillance in the hands of those who are comfortable and have the expertise with respect to what to do with the information. So if you're still with me, I want to switch to another area that I think as parents, when you go through family meetings, this is a topic that is discussed. I, as an oncologist, have talked to families myself when we talk about side effects of chemotherapy. I think the reality in terms of the damage to the gonads, whether it's testis in males or ovaries in the females. But I think, a lot of times the child who is diagnosed, and at the time the thought process is about the child itself, their toddlers and puberty may not necessarily be the forefront of thinking. But as you venture on into the survivorship realm, then these are questions that, is my child going to go through puberty or not? And then, kind of some of the fertility consequences. So I think it's important to realize that the alkylator chemotherapy, and especially for males in transplant, that higher dose of alkylators, it's a primary damage or impact at the testis for males, and then same thing at the ovaries. So in general, high-risk neuroblastoma therapy is more direct damage to the gonads rather than damage to the hypothalamus or the pituitary, because those are usually based because of radiation. And that kind of is true for males. I think overwhelming majority of males with high-risk neuroblastoma diagnosis who enter survivorship will go on to initiate puberty and essentially get themselves through puberty. What we tend to see is about a third of the males will not go on to fully virilize. So this is where it's really important for an endocrinologist to follow our patients. And there are male survivors that I actually start adult testosterone replacement once they're into young adulthood, because they have not been able to, with time and patients, what you can see is they just are not able to fully virilize themselves. And you need to make sure that young adult males have appropriate levels of testosterone for their age. So I think that that's an important, area of intervention. But what is more common, especially in males who have high-risk neuroblastoma therapy, particularly with autologous stem cell transplant, is the damage to the Sertoli cells and the infertility that comes with the alkylator exposure. And so that, from a blood work standpoint, we can see that with elevated follicle-stimulating hormones. So sometimes you can see that in the blood work. On exam, as an endocrinologist, I can tell that because the volume for the testis is lower than what it should be. And then there are other, ways to do from a laboratory evaluations that are not validated, but at least they're associative. That's the inhibin B level that can be low, but the gold standard is usually a sperm analysis that is able to reflect the inability to, make sperm. And that, again, comes directly from Sertoli cell damage. The Leydig cells in the testis are what are responsible for making testosterone, which is why, despite this type of treatment exposure, it's usually primarily the Sertoli cells that get affected. And then the Leydig cells, usually it depends on the cumulative exposure of that, alkylator or the cyclophosphamide equivalent dose. But most boys can make it through puberty. It's about a third who eventually will need to be on testosterone replacement. The story gets a little bit more convoluted and challenging with females, but I do want to make sure that I kind of review some of the terminology so you're aware of what do we mean by when we say acute ovarian failure or premature ovarian insufficiency or POI. So acute ovarian failure means that basically the ovaries have been impacted to an extent where the child is unable to actually go through or demonstrate ovarian function. So these are girls who just are unable to go through puberty, and that's within the window, within the 5-year window of their cancer diagnosis, or if by age 18 they've never been able to actually initiate puberty or have a period, at least you think about those are patients that have acute ovarian failure. Now, premature ovarian insufficiency is there's laboratory evidence that the ovaries have been impacted by treatment. Some of those girls actually can go on to get themselves through puberty and menarche, which is the first period, and then have very irregular periods and go on to have cessation of ovarian function at a much younger age. So traditionally, that's age 40, but I would say majority of our high-risk neuroblastoma survivors with premature ovarian insufficiency will actually show loss of ovarian function probably in their late 20s and 30s. So I think that this is an important area. I think the more survivors we have, the better we are, learning about that. And I think this is an important study that was just published by Dr. Danielle Friedman as the lead senior author from Memorial Sloan Kettering. And again, this is a single institution experience, but I think it just shows very nicely that if you take all comers of high-risk neuroblastoma survivors, so they had 83 patients, so I think for a single institution, that's an excellent number. And then you look at survivors who were treated with just chemotherapy, only about a third of their cohort, and survivors that had both chemotherapy as well as, myeloablative, treatment. So they went through an autologous stem cell transplant. So again, bringing on more intense therapy. So about 2/3 of their cohorts of 51 patients. So as you can see here, patients who only had chemotherapy are more likely to spontaneously go through puberty and have menarche, so the first period. If you did blood work evaluation, so if you measured, let's say, LH, FSH, more likely to see, at least in patients who had an autologous stem cell transplant, that the FSH value is greater than 15. So again, in the perimenopause to menopausal range, let's say if one were to do that blood work on adult, or those are the ranges that basically have been established for adults who are, moving towards that part of lifespan. But the premature ovarian insufficiency, as you can see, so, 30 out of 51 patients, so a much higher percentage. So that risk is almost fourfold higher in patients who actually have to go through autologous stem cell transplant. And I think the figure here that I wanted to share with you is equally very telling, that especially as the CED, which is the cyclophosphamide equivalent dose, which is how we actually think about the alkylator exposure that is toxic to the gonads, as that CED is much higher, you have a much higher range of pediatric survivors or high-risk neuroblastoma survivors with premature ovarian insufficiency. What I did not put on these slides, as an interest of time, is some of the other, for example, collaborative efforts that I have done with the Childhood Cancer Survivor Study, where we actually looked at predictive modeling to use, to validate models based on treatment exposure for both acute ovarian failure and premature ovarian insufficiency. And the actual radiation to the radiation that the prescripted ovarian radiation dose plays a huge role in terms of being able to predict the damage to the ovary. So I think that these tools are now more available. Some of these studies at least are highlighting that in general, puberty may definitely, I think, for girls be a bigger challenge that, certainly endocrinologists will be part of that care. And I think estrogen and progesterone replacement are critical for, our teenagers and young adults, because estrogen is not only important for bone health, but rather cognitive health, cardiovascular health. So I think that those are all important roles that estrogen plays in cardiometabolic health. So I think that's why it's really important, if we have females who, meet those criteria, that we do not withhold or do not delay ovarian hormone replacement. So I think with this, I'm going to shift to the latter part of the talk and just fairly briefly give you some, highlights about what we need to think about our survivors with respect to body composition, muscle mass, and how that can set them up also equally for toward late effects. And again, when you look at survivors in general, I think neuroblastoma survivors, sarcoma survivors as well, like both males and females, are actually known to have lower body weights compared to, let's say, leukemia survivors. And so what we wanted to do is get a better delineation. So we did DEXA evaluation. That's a gold standard way of evaluating body composition. So we again took our high-risk neuroblastoma survivors, we recruited and compared them to healthy controls. And I think what, this slide here on the bottom is showing is when you look at the total body lean mass in our survivors compared to healthy controls, our survivors have significant lower, and these are survivors who are several years off of therapy and now, as young adults, so they have significant sarcopenia. And then if you actually focus on the appendices, so appendicular lean mass, which is, again, one of the newer ways of really evaluating an adult for sarcopenia and the risk and the morbidity that comes with that, much higher risk. As you can see, that sarcopenia is a lot more evident, and significantly lower compared to, matched control. So I think that this is an important area. We need to focus. We need to really, help our survivors with, resistance training, with exercise, because I think we have to focus on muscle. It's not an exciting organ. Not many people think about muscle as one of the things that they need to, kind of invest in, but it does have some snowball effects. And I think diabetes is one of the reasons where you can actually see muscle is an important organ for insulin sensitivity and uptake of glucose, as well as then later on frailty and the challenges and accelerated aging that comes with that. But I think our survivors actually have a unique predisposition to insulin resistance, and a lot of that has to do with the other portions of the neuroblastoma therapy. So for example, abdominal radiation, back in the days when we used to give TBI. So I have a fair number of now older survivors in there as a young adult who had total body radiation as well as abdominal radiation. And these patients have visceral adiposity, liver fat deposition, and significant insulin resistance that's really magnified, especially in the face of sarcopenia. So I think that this is an area that we're starting to learn more. I and some of the other investigators have done a little bit more mechanistic studies to just really show some of the impacts of this, insulin resistance and the challenges in, with respect to diabetes mellitus that we see in survivors. And this, for example, again, Laurie Cohen and Lisa Diller were from a single institution. I think that's one of the things that, hopefully larger cooperative studies will be able to kind of give us more of an indication. And I think mechanistic studies that lead to eventually interventions can all really provide, helpful insight. And then lastly, I think that this is one of the areas that has garnered some attention using kind of the large data sets that we have and some of the effects of radiation to the pancreas. So again, the adrenals are not that far from the from the pancreas. And so direct effects of radiation dose to the pancreas particularly can impact, the beta cells, and so have, paucity of insulin secretion as well as increased visceral adiposity that causes, resistance to the amount of insulin secretion that's there. And that kind of is directly correlated with the doses of radiation that we see. Certainly higher doses of radiation, it's more notable, but even in the dose range for high-risk neuroblastoma survivors. And so lastly, what I leave you with is the importance of programs that are focused on taking care of late effects. So whether it's survivorship, so we have an endocrine late effect program that I established here at CHOP. Our mission is really to focus on our patients, to have timely, evidence-based, and more importantly, proactive. So I do not wait for the oncologists to send me patients. We proactively identify, and high-risk neuroblastoma is one of our high-risk survivors where we like to proactively have those patients join us so I can follow them along with their oncologist of therapy even before they make it to, the survivorship team. So I think that that's really important, and some of the ways that we can, provide consistent care with the same providers who at least have familiarity with the guidelines, to make sure that we, provide, we, have data that clinically can help us with QI, projects and, research to support our trainees. And prior to, for example, inception of this program, the ELECT program, what we noticed is, when we did the numbers is, over 80% of patients actually who met criteria for high risk were not being, referred to endocrinology. And so really it was the tip of the iceberg where the oncologists were recognizing something is wrong. And since we have been able to have this clinic, the number of screens and ways that we are in sync with the guidelines really has increase because you have a dedicated group of endocrinologists that focus on these patients and are really familiar with the challenges. So I know I took you on a whirlwind. There's a fair bit more that I usually, at least, as I said, spend more time during clinic visits talking to families. This is, education that needs to happen over time that I am certainly very much dedicated to helping our families, our parents, and most importantly, patients. My job is really to teach my patients, to help give them the understanding and the knowledge they need to know, especially as they embark on young adulthood. And, kind of highlighting some of the risk factors of treatment exposure. So what is the impact of radiation therapy down the road? And especially this intense multimodal therapy that we bring on combining, chemotherapy, immunotherapy, biologics. I think a lot of these, neuroblastoma is a first for a lot of these treatment regimen. So I think the understanding the late effects, and especially not just in childhood, but as our survivors embark into adulthood. And I think, it's important for providers to have a high index of suspicion, to have early, recognition and treatment, and also long-term surveillance. So I think that this is why it's important for you to continue to see your endocrinologist as well as, transitioning to adult endocrinologists. And what we really need are cooperative, multi-center studies that are longitudinal and focused on specifically high-risk neuroblastoma survivors. So there's a fair bit of effort, and hopefully, now that we have the LEARN cohort, we will be able to kind of work with the neuroblastoma parent community as well as our own survivors to be able to delineate and increase their own, engagement with respect to research studies, because I think that that's really the best way that we can, address the late effects. So I think cure is really important, but equally addressing the late effects to me is the cornerstone of what we need to do. So with this, I wanted to thank your time and effort. Again, I wish I could have been there in person, but at least sending you, as I said, a warm greetings from the city of brotherly love from the Children's Hospital of Philadelphia. I wanted to acknowledge my grant funding over time, which has really helped with a lot of the studies that I shared. And then last but not least, I wanted to make sure that you had this email in case you needed to specifically reach with questions as well as referrals. So we are more than happy to kind of help provide second opinions and care for any of our patients who are at different areas where they may not have expertise. So I usually make sure that I, help, and certainly have had patients from many of the different states who have come at least for second opinion, so I can provide the education and the guideline. So I think with this, I'm happy to stop. And I don't know if I know we started late, so I'm not sure if there's time for questions or how we want to proceed.
We're going to go ahead. If anybody does have any questions, if you can go up to the microphone, we'll be happy to take your questions. Hold on, we've got a couple. Go ahead.
Hi, thanks for being with us. I had a question. We have a 13-year-old daughter, and she needs estrogen replacement. That's becoming clear. She just finished treatment, so we're just at the point to start it. And we're in Arkansas. We don't have necessarily, the type of expertise available. But one of our thoughts was, is it okay to wait for estrogen to let her have more time to grow, since we know that window of growth kind of closes? Or would you recommend just starting it as soon as possible?
Yeah, so I think that that's an excellent question. There's more that goes into that equation than just the age. So I think I typically at least look to see where that bone age x-ray is to see if your chronological age and your bone age are the same or is your bone age behind. So I think if the bone age is, let's say 10 or 11, that's the clock that I use, and I step back or at least wait to kind of provide at least what is necessary from a timing wise. But I think if someone's bone age is 13 and a half, delaying the estrogen further, I think actually is not going to really buy you much in that equation. If anything, actually, the estrogen can stimulate some growth if a child does not have growth hormone deficiency. I think that actually does help. And again, you have to be judicious. Mother Nature, I always tell my patients, Mother Nature doesn't do this overnight. Like you don't get like the whole point of estrogen treatment is very low dose, just like the body would do when you go through pubertal development, is to eventually have menarche around 2 to 2.5 years after estrogen exposure. So that's why it's a fairly low dose, and then you slowly increase that. So I think I would be a proponent if the bone age is close to chronological age to actually introduce low dose estrogen, and then slowly typically you have options of what types of estrogen, how you would introduce estrogen, but typically I think transdermal estrogen is probably the preferred way because you bypass the liver and the levels that get in the blood are very similar to what eventually the ovaries, if they were doing this on their own. So at least there's a shift now, and a lot of us in the field are a high proponent of transdermal estrogen therapy, and eventually you will introduce progesterone probably in 2 years.
Okay. We're going to have a question here first, and then we'll go back to...
Can I follow up? Okay, would a hand x-ray be the preferred way to find bone age? Her hand x-ray did show the same age, but I also noticed that you showed those leg x-rays.
Yeah, so that was a unique case that I was trying to make a point where a kid was not growing, even though we were giving growth hormone, and the bone age, which is the classic standard of what we do. So sometimes the point of that was, if things don't make sense, then you need to kind of increase your investigation. So I think that's where we just had a kid who just was not growing on growth hormone, even though the bone age x-ray. So that doesn't represent all neuroblastoma patients. I just wanted to kind of highlight what happens with some patients with, the high dose cisretinoic acid that you get and the fusion of growth plates. So, and we don't see that. That's actually less than 10% of patients, but the hand x-ray is the bone age. So if the bone age is congruent with the chronological age, I think delaying estrogen is not going to really be, that useful. So I think if she was my patient, obviously I would have to look at all the data, et cetera, but I would not be in favor of delaying estrogen, treatment.
Okay. All right. Here.
I know you discussed a little bit about seeing you after radiation, but when is, how long? We've never met with an endocrinologist, or it's never been brought up. Are there things we need to be proactive about? Should we be seeing you now? We've been doing it for 4 years, so it's been a while. So yeah.
I think at CHOP, I have a nice working dialogue with Ro Bagatelle, a lot of our providers who see, obviously Dr. Maris and Mose have a very unique program where, those patients that they refer to me have more challenges because of the progressive refractory nature of the children that they see. But with our just neuroblastoma program at CHOP, our providers, we have an open dialogue. So I think once kids are a couple of years off therapy, if there's an active issue like thyroid levels are off, they send them to me earlier. But I think even if 2-3 years, the scans are at least confirming that there is, appropriate at least remission. I like to have the first visit with the families, and I tell everyone this is an educational visit. I want you to know. And then, we can kind of, for some kids, I actually identify things that I need to see them every 6 months versus I may bring them back once a year.
Okay. So if they're in active treatment and there's no thyroid issues or anything, there's no reason. Okay.
Yeah. Unless there's, as I said, I've had to help our team if the patient has adrenal insufficiency for whatever reason, they're going to, immunotherapy. Those are the reasons I come on board to help the active team to kind of, as an endocrinologist, to address those. But otherwise, during active therapy, I don't necessarily have, I'm always available for opinions, but I don't, I think we need to focus on the neuroblastoma therapy.
Thank you. We'll do those 2 questions, and then that will be it. We have to move on then.
Perfect. Thank you for the talk today. We had someone in yesterday talking about, or a fertility doctor talking about some of the advancements there, and I was curious if there's opportunities or what your thoughts are if you were able to preserve healthy ovarian tissue, for instance, or if you're kind of going through the process of chemo, healthier than it may be kind of a year or 2 from now, would that help in some of these kind of developmental effects? And are there kind of studies going into that? And even if there's not anything today, I guess one of the things I took away from the conversation yesterday was like there might be an opportunity to freeze that healthy tissue, and then as clinical trials come along, you would then be able to leverage that that tissue for and put it back into the body to help kind of jumpstart some normal processes, if you will, in the body.
Correct. I mean, I think so. Most, for males, that especially in the toddlers, that's the biggest challenge because you haven't gone through pubertal development. You can't produce sperm. And so that's where testicular preservation is part of research studies. I know that Dr. Ginsburg at CHOP has a very active program. She's partnered with a scientist at Penn. And so I know that that's a very robust and active program. I think equally for females who are pre-pubertal, I think that the preservation of ovarian tissue, at least based on the kind of treatment that you will be going through, is usually offered. Especially with high-risk neuroblastoma. So I think the challenge is pre-pubertal versus post-pubertal. It's not considered research. It's actually standard of care. However, the reality is also we know that not all insurance companies are created equal, and the coverage is not equally the same, and there's annual fees, et cetera. So the financial toxicity can be fairly, significant even in families where their child is capable of going through that. I think the challenge of having a toddler is usually where some of those questions have not been answered. And I absolutely think that with protocols that are available, these are opportunities that at least give us ways to look at what we consider primary versus secondary prevention to really be able to kind of address some of these questions that we would not be able to do once chemotherapy has been, once the oocytes have been exposed. For females, your eggs are, that's it, like you're born with the number of eggs that you're going to have at lifespan. So I think that that's why it's very important to at least see what are the opportunities that we can do. And I think we've still, like even in the span of my years in medicine from training to practice, I think we've come a really long way. So I know that this is an active area of investigation and understanding. And I think some of the benefits of these large epi studies, I kind of highlighted the, risk modeling program, the way we can just have these high risk models. We can predict like this is a patient that's going to be high risk for ovarian failure and premature ovarian insufficiency. And so I think that can really provide the guidance in terms of increasing at least the guidance to be able to proceed with what may be, experimental, or at least some of these studies at this point.
Okay, but to the extent possible, like putting aside the financial burden and also putting aside, with all else being equal with treatments and everything, you would in general recommend trying to preserve some of that healthy tissue because you might be able to leverage that in some form or fashion later on to help in this. Is that fair?
Okay. I think that's fair. I think that I don't think we have really been able to, the talk has not been able to really leverage to get that healthy tissue to basically produce the, hormones to just bypass hormone replacement therapy. I think the question really is on the oocytes and really being able to preserve fertility.
Okay, thank you.
Next question, I have one more after you, so real quick one.
I'll go quick. Hi, how are you? We are a St. Chris family. We've met with Dr. Bagatelle a few times as well. So our daughter just wrapped up immunotherapy in June. She will be 4 next month. I guess the question here is that chart that you had up is if X age, then this is when you start to consider all those things. At what point post-treatment do you start consider doing the bone age and all that if they've gone through, the Accutane and all of that? I think the beauty of pediatric growth is
it gives you so much information. So I think an accurate measurement and the trained eye of an endocrinologist, or even at least a provider that your either pediatrician, if they have the time and they're looking at it, or at least, the providers who are looking at the growth chart. So I think you don't need a bone age x-ray. So as a child that's appropriately growing has a good growth rate, I don't think a bone age is really, it's a lot of radiation that is not going to give you the information that you need. I do a bone age when I have to make treatment decisions.
Gotcha.
And I think, and the younger you are, actually, the bone age is not as helpful. So a lot of times I may even identify a growth issue in a younger child, let's say a 4-year-old that comes to me, and I may not even get a bone age, because remember what I said is it's what we have. It's the only tool that is basically what we use in clinical pediatric endocrinology, but it's not a perfect tool.
Okay.
So I'm cognizant when I actually order it, because willy-nilly I don't like to also expose children for radiation for the sake of just getting a bone age.
Gotcha. And then as far as like if you come from a long line of thyroid issues, do you have a higher risk of having an issue post-treatment, or it's just like it doesn't really matter?
I think it depends on what kind of thyroid issues. So I think for me, if someone says, I have a lot of thyroid cancer in my family, that, I do listen to that, just because you may have like a slight higher background risk, and then we're giving you treatment that causes DNA damage that can certainly put you at a different risk profile for thyroid nodules and thyroid malignancy. I think hypothyroidism, which is the most common thyroid disorder that can happen. So a lot of times thyroid levels are off if you get the blood work during SSKI, because the iodine in SSKI can impact your, and it's mild and it tends to usually go away. That's usually the first rule when people email me and I'm like, was this on SSKI? We need to repeat it. But, certainly I think the exposure, either MIBG and, if someone had mediastinal reasons to get radiation to the neck, like a lot of that I think is going to basically supersede or overcome. So even in patients who did not have thyroid disease, your risk might just be slightly higher, but I don't necessarily feel like it's going to, make it or break it. So, it's just, I worry more about the treatment exposure putting you over that risk bracket.
Dr. Moab, are there other centers at other hospitals similar to what you do, or are you the only one doing this comprehensive program?
So I think the endocrine late effects program is specifically at CHOP, but there are institutions. So I think, St. Jude obviously has a fair number of endocrinologists that take care of pediatric patients. Dr. Wasim Shamatli, who's now at Pittsburgh, is doing a fair bit with endocrine late effects. I think, the Memorial program has a really nice program that they also include endocrine. In their survivorship program that they have an endocrinologist. So I think, there are definitely, this is an area that has a fair bit of recognition even within the divisions of endocrinology, that it's not a one-size-fits-all, like different endocrinologists taking care of this. So more and more, I think centers are focusing on identifying endocrinologists that at least predominantly take care of the cancer survivor population. I will say that an endocrinologist who has really done a lot of, work with high-risk neuroblastoma, I think Lori Cohen, who was at Boston Children and now she is the division chief of endocrinology at Mount Sinai. She has a lot of experience in high-risk neuroblastoma survivors. Myself, I think, Anton, who's, Anton Zoltan, who's at Memorial Sloan Kettering. So like we're at least endocrinologists who have seen so many high-risk neuroblastoma survivors, where some of the challenges even within the spectrum of high-risk neuroblastoma therapy are, at least we have a lot of experience with that. But the thyroid surveillance, I think, is unique to CHOP. So I wanted to make sure that, that's not an area. I am very active in trying to make a case, not just me, Andy Bauer, who's my colleague and one of the thyroidologists in this country. So I think there's a lot of pushback, and I recognize we have the expertise at CHOP. I am fortunate I can pull up my ultrasounds and look at that and be able to say oh, this is abnormal, or no, we can just watch that. And I can directly communicate with my patients. Not many centers actually, have that expertise, and the radiologist may also not be as comfortable reading the thyroid ultrasound. So it's not something that I think makes sense for you to, just ask any of the providers who may not necessarily have the comfort level, because I think if you do a screening test, you really need to first and foremost be available to address what to do with the results. And, the golden rule is not to, result in unnecessary anxiety based on a test result that may be misinterpreted. So I think that those are equally really important when you're thinking about a surveillance protocol.
Thank you.
Yeah, so hopefully any questions, let me know. As I said, I'm more than happy to, sometimes just a baseline referral to us. If you really want to, then I can provide guidance for local physicians, and I have collaborated and worked also with local endocrinologists. So I think it just really depends on what you're, looking for. And, my goal is always to share the knowledge base that I have to, help our, survivor community. So if there's anything that I can do, please don't hesitate.
Thank you very much. We really appreciate it. Thank you for joining us.
You're welcome. Take care.
Mm-hmm.